You are taking your medication every day. You are watching what you eat. You are checking your blood sugar, and the numbers are still not where they should be. There is a reason for that, and it has nothing to do with how hard you are trying. Most doctors never mention it. Most diabetes advice never covers it. It is 3 minerals, and diabetes is quietly draining all of them from your body every single day. Today, I am going to show you exactly which ones, why your body is losing them, and the simple foods that can start replacing them this week. My name is Dr. Alan Mandel. I am a preventive medicine physician, and in my decades of clinical practice, one of the most consistent patterns I have seen in patients managing type 2 diabetes is this. They are doing everything they were told to do, and something is still working against them. That something has a name, and it is not a new medication. It is not a stricter diet. It is not more willpower. It is a mineral problem that the disease itself is creating inside your body right now every single day without any visible warning sign. Before I explain what these minerals are, I need you to understand one thing about diabetes that most clinical appointments never cover clearly enough. When your blood sugar is high, your kidneys work harder to remove the extra glucose from your blood. They filter it out through your urine. This is your body trying to protect itself. But here is what nobody tells you. When your kidneys flush out that extra glucose, they do not flush out glucose alone. They take minerals with it. Important minerals. Minerals your insulin needs to work properly. Minerals your nerves need to stay healthy. Minerals your heart needs to keep beating steadily. And because diabetes keeps blood sugar elevated day after day, this mineral loss is not a one-time event. It is happening continuously, quietly. Every time your glucose goes up, this is why you can be taking your medication, eating carefully, and still feel like something is missing. Because something is. 3 things specifically. Let me show you each one. The first mineral is magnesium. Magnesium is not something most people think about, but if you have diabetes, your body is losing it faster than almost anyone else. Every time your blood sugar rises and your kidneys flush the excess glucose out through urine, magnesium goes with it. This happens every day, sometimes multiple times a day, and over months and years it adds up to a significant and serious depletion. Here is why that matters so directly for your blood sugar. When insulin arrives at a muscle cell to deliver glucose, the cell has to respond. It has to open up, accept the signal, and activate the pathway that moves glucose inside. That entire process requires magnesium. Without adequate magnesium, the cell responds poorly to insulin. The door opens slowly. Less glucose gets in. Blood sugar stays higher than it should. This is insulin resistance, and magnesium deficiency is one of the things that makes it worse. So, the cycle looks like this. High blood sugar causes magnesium loss. Magnesium loss makes insulin work less effectively. Less effective insulin means higher blood sugar. Higher blood sugar causes more magnesium loss. It goes around and around, and the number on your glucose meter keeps reflecting it every morning. Magnesium also powers something called ATP. This is the fuel your cells run on. Every movement you make, every thought you have, every heartbeat requires ATP, and ATP requires magnesium to function properly. This is the direct biological reason why so many people with diabetes feel exhausted even when they are sleeping enough and eating reasonably. It is not weakness. It is a mineral deficiency affecting your cell's ability to produce energy. The nerve symptoms many people experience, the muscle cramps at night, the twitching in the legs, the tingling in the feet, the difficulty sleeping, the feeling of anxiety that has no clear cause, all of these can be connected to low magnesium. Because magnesium is what keeps nerves from firing too easily. When it is low, nerves become overactive. The result is exactly those symptoms that most people assume are simply part of getting older or part of having diabetes. They are not inevitable. They are in many cases a sign of something that can be addressed. The foods highest in magnesium that are also appropriate for blood sugar management are cooked dark leafy greens, particularly spinach. 1 cup of cooked spinach provides close to 40% of your daily magnesium needs. Cooking matters here. Raw spinach has the magnesium locked inside the plant cell walls. Cooking releases it and makes it available for your body to absorb. Always add a small amount of olive oil or butter when eating cooked greens. Several nutrients that help with magnesium absorption require fat to enter your body properly. Pumpkin seeds are another excellent source. A small handful, approximately 1 ounce, provides close to 37% of daily magnesium needs. They can be added to any meal or eaten as a snack. Almonds, avocado, and dark chocolate above 70% cacao also provide meaningful magnesium in portions that do not significantly impact blood sugar. For supplementation, the form matters more than most people realize. Magnesium oxide is the cheapest and most widely sold form. It is also the form that absorbs most poorly and causes the digestive discomfort that makes people stop taking magnesium. Magnesium glycinate is the form with the best absorption and the least digestive side effects. This is the form to look for if you choose to supplement. A typical starting dose is 200 milligrams per day with a meal, increasing gradually based on tolerance and response. Two habits that quietly drain magnesium faster than the disease alone are high sugar intake, which drives the same kidney flushing process that elevated blood glucose does, and alcohol consumption, which directly impairs the kidney's ability to retain magnesium. If either of these is present alongside diabetes, the depletion accelerates significantly. I want to tell you about a patient I will call Helen, 71 years old, type 2 diabetes for 8 years, on 2 medications. Her fasting glucose each morning was consistently between 130 and 145. She had reduced carbohydrates substantially. She walked daily. She described herself as doing everything right and feeling like nothing was working. When we talked about her symptoms beyond the glucose number, a pattern appeared. Leg cramps at night that woke her from sleep several times a week, persistent fatigue that she had assumed was simply age, tingling in both feet that her previous physician had attributed to neuropathy from the diabetes itself. Her magnesium level when tested was at the very bottom of the standard reference range. Standard reference ranges for magnesium in blood are not sensitive indicators of total body magnesium status because the body maintains blood magnesium at the expense of magnesium stored in muscle and bone. By the time blood magnesium falls visibly low, total body depletion is often already significant. Helen added cooked spinach to one meal each day, a small handful of pumpkin seeds as an afternoon snack, and began magnesium glycinate at 200 milligrams each evening with dinner. Within 3 weeks, the leg cramps had reduced substantially. Within 6 weeks, her fasting glucose had shifted to a consistent range between 112 and 122. Within 3 months, her physician noted the improvement and reduced one of her medications. The food changed. The mineral environment changed. The number followed. The second mineral is zinc. Zinc is lost through the same urinary process as magnesium, but it has an additional role in diabetes that makes its depletion particularly damaging. Your pancreas, the organ that produces insulin, stores insulin in a very specific way before releasing it. Insulin is held in small storage compartments inside the beta cells of the pancreas, and it is stored in a crystalline structure that requires zinc to hold its shape. Zinc is not simply present in these storage compartments by coincidence. It is structurally necessary for insulin to be stored properly and released in the right amount at the right time. When zinc is depleted, the pancreas cannot store or release insulin as efficiently. The insulin secretion process becomes less precise, and in a person who already has type 2 diabetes and whose beta cells are already under significant stress, adding zinc depletion to that environment compounds the problem at the source. Beyond the pancreas, zinc is required at the muscle cell level for the signaling process that follows insulin's arrival. It works through a different molecular pathway than magnesium, but toward the same end, better glucose uptake into muscle cells. When both zinc and magnesium are depleted simultaneously, which is the common state in people with long-standing type 2 diabetes, the insulin signaling cascade is being impaired at multiple points at the same time. Zinc is also one of the body's most important antioxidant minerals. It is a core component of the enzyme superoxide dismutase, which neutralizes some of the most damaging reactive oxygen molecules produced by the metabolic stress of elevated blood sugar. When zinc is insufficient, the oxidative damage that accelerates diabetic complications in the nerves, the kidneys, and the eyes proceeds faster. This is not a theoretical concern. It is the mechanism through which zinc deficiency contributes directly to the progression of neuropathy, nephropathy, and retinopathy in people with diabetes. The signs of zinc deficiency are specific once you know what they look like. Wounds that take longer than expected to heal are one of the most reliable indicators. Zinc is required for every stage of wound repair. A small cut or blister on the foot that is still present 2 weeks later is not simply slow healing. It may be zinc deficiency delaying a process that your body is trying to complete. Getting sick frequently, catching colds or infections more easily than you feel you should, reflects zinc's role in immune function. Natural killer cells, the immune cells that attack viruses and bacteria first, require zinc to function properly. Zinc deficiency impairs this frontline immune response. Intense sugar cravings, unexplained hair thinning, skin that is dry and slow to repair, and a reduced sense of taste or smell are additional signs that zinc status has declined. The most bioavailable food sources of zinc are animal-based. Oysters are the most concentrated zinc food available. 3 medium oysters provide more than 200% of the daily requirement. For people who eat beef, a 3-ounce serving of grass-fed beef provides approximately 40% of daily zinc needs. Beef liver is even higher. For those who prefer plant-based sources, pumpkin seeds are again highly relevant, providing approximately 50% of daily zinc needs per ounce. This makes pumpkin seeds one of the most practical additions to a diabetic diet, as they address both magnesium and zinc simultaneously in a food with minimal glycemic impact. Chickpeas and lentils provide zinc as well, but plant-based zinc is bound to phytic acid in the plant cell wall, which reduces how much the body can absorb. Soaking or sprouting legumes before cooking reduces the phytic acid content substantially and improves zinc uptake significantly. This preparation step matters if plant foods are the primary zinc source. For supplementation, zinc picolinate and zinc bisglycinate are the forms with the best absorption and the least digestive side effects. A typical range for people with diabetes is 15 to 25 milligrams of elemental zinc per day. Important note, at sustained doses above 40 milligrams, zinc begins competing with copper for absorption and can gradually deplete copper. If supplementing above 15 milligrams long-term, include a small amount of copper, typically 1 to 2 milligrams, to maintain the balance between these two minerals. The third mineral is chromium. Chromium is the least familiar of the three. It is also the one that acts most directly on the insulin receptor itself. In research conducted over several decades, scientists identified a compound that dramatically improves the ability of insulin to bind to its receptor on the cell surface. This compound, which they called the glucose tolerance factor, has chromium as its active mineral component. Here is what this means in practical terms. Insulin arrives at your muscle cell and reaches for the receptor, the molecular structure on the cell surface designed to receive it. For that connection to be made efficiently, for the insulin signal to be transmitted into the cell clearly and completely, the receptor needs to be in a state that allows strong binding. Chromium is what helps maintain that state. When chromium is depleted, insulin binds to the receptor less effectively. The signal is weaker. Less glucose enters the cell per unit of insulin. Blood sugar remains higher than it should given the insulin that was produced. This is not the same mechanism as magnesium deficiency, which impairs what happens after insulin binds. Chromium deficiency impairs the binding itself. They are two different failures at two sequential steps in the same process. And in many people with type 2 diabetes, both are happening at the same time. Chromium is lost through urine in the same way as magnesium and zinc when blood glucose is elevated. But chromium has an additional depletion mechanism that is particularly relevant for people over 60. Cortisol, the stress hormone that rises with anxiety, poor sleep, physical illness, and the emotional weight of managing a chronic condition, increases urinary chromium excretion directly. This means that the stress of living with diabetes accelerates the chromium depletion that the disease itself is already causing. The more stressed and sleep-deprived a person is, the faster their chromium status declines and the harder it becomes for insulin to do its job. The signs of chromium deficiency overlap with the general experience of poorly controlled diabetes. Blood sugar that is harder to control despite consistent effort, intense carbohydrate and sugar cravings, fatigue and mental fogginess, mood swings that seem disproportionate to circumstances. These are not simply symptoms of diabetes. They can be signs that chromium depletion is worsening the underlying insulin resistance in a way that dietary and medication management alone cannot fully compensate for. The most practically accessible chromium-rich food is broccoli. Half a cup of cooked broccoli provides approximately 50% of the daily chromium requirement and is simultaneously an excellent source of fiber, vitamin C, and sulforaphane, a compound with documented anti-inflammatory properties. Broccoli twice a week is one of the most efficient nutritional investments a person with diabetes can make. Lean beef provides approximately 25% of daily chromium needs per 3-ounce serving. Eggs contribute 10 to 15% per large egg. Brazil nuts are among the most chromium-dense plant foods available, with a single nut providing close to 30% of the daily requirement. For supplementation, chromium picolinate and chromium polynicotinate are the forms with the best clinical evidence for blood sugar benefit. The typical effective dose range is 200 to 500 micrograms per day. Begin at 200 micrograms and assess the response over 6 to 8 weeks before considering adjustment. Chromium works gradually. The research shows meaningful effects on fasting glucose and insulin sensitivity developing over 8 to 12 weeks of consistent use. The habits that accelerate chromium depletion most aggressively are high refined carbohydrate and sugar intake, which increases insulin demand and drives chromium excretion; poor sleep, which elevates cortisol and its chromium depleting effect; and alcohol, which impairs chromium metabolism independently of its other effects on blood sugar. Now here is the complete picture of why these three minerals work together rather than independently. Chromium helps insulin bind to the receptor effectively. Magnesium enables the receptor to respond to that binding signal properly and activate the intracellular pathway. Zinc is required for insulin to be stored and released from the pancreas correctly, and for the downstream signaling inside the cell that moves glucose transporters to the cell membrane. These are three sequential steps. Three different points in the same process. If any one of them is compromised, the entire insulin signaling pathway works less efficiently. If all three are compromised simultaneously, which is the common state in people with long-standing diabetes, the cumulative impairment is substantial. This is why addressing glucose alone through medication or dietary restriction, while leaving these mineral deficiencies unaddressed, produces incomplete results. You are managing the output of a system whose components are not working properly. The number on the meter reflects that incompleteness every morning. Here is where to begin this week. Add cooked spinach to one meal each day. Prepare it with a small amount of olive oil. This single change addresses magnesium in a bioavailable form that your body can use efficiently. Add a small handful of pumpkin seeds as a daily snack or meal addition. 1 ounce addresses both magnesium and zinc simultaneously with minimal glycemic impact. Add broccoli to 2 meals this week. Half a cup cooked at each meal begins addressing chromium in a form your body recognizes and processes efficiently. If you choose to supplement, discuss it with your physician first, particularly if you have kidney disease or are on medications for blood pressure, heart rhythm, or glucose management. If supplementation is appropriate, prioritize magnesium glycinate, zinc picolinate or bisglycinate, and chromium picolinate. These are the forms with the best absorption and the most clinical evidence. Reduce the habits that accelerate depletion beyond what the disease alone produces. High sugar intake, alcohol, and poor sleep all worsen the mineral loss that is already happening. Addressing even one of these reduces the rate at which your body is losing what it needs. Evaluate over time. Magnesium effects on sleep, cramping, and nerve symptoms often appear within 2 to 4 weeks. Fasting glucose changes typically become visible at 4 to 8 weeks. Chromium effects on insulin sensitivity develop over 8 to 12 weeks. These are not overnight results. They are the timeline of genuine biological change. The number you check every morning is not just a glucose reading. It is a report on everything happening inside your cells, on whether your insulin receptors are responding properly, on whether your pancreas is releasing insulin efficiently, on whether the minerals your body needs to make all of that work are present in adequate supply. For many people with type 2 diabetes, they are not, and no one has told them. Now you know. The medication is doing what medication can do. The diet is doing what diet can do. These three minerals address what neither of those alone can fully reach. I am Dr. Alan Mandel. If this gave you a clear explanation that your clinical appointments have not provided, share this with someone who is managing diabetes carefully and still cannot understand why the numbers keep reflecting something more than diet and medication can explain. I will see you in the next one.